because we are going to find where it applies very well. If you remember our case in point some time back that we presented, it should also be reflecting here. Look at it in terms of definition of preeclampsia. So we have many reasons in Africa. The outcomes are usually worse, and Uganda in particular. And our moderator our moderator gave a statement that Soroti Teso region is among the leading in regions in which regions in which preeclampsia is causing a lot of mortality and morbidity, possibly, of course, because usually when we see a mother dying, there are several other women who are surviving with severe complications. And the reasons are, and I'm very sure these ones apply to our region, but they also apply to many other regions in Uganda. Late antenatal care, no antenatal care sometimes, poor awareness, people are not aware about this disease, this illness, poverty. We know that our region is among the regions which are not endowed economically. Then poor nutrition, those are some of the patient factors. Health system factors, delayed referral, weak ambulance system, limited ICU, HDU space. Our intensive care at Soroti Regional Referral Hospital, if I remember very well, it has 2 or 3 functional beds. The rest are really not functional ICU beds. Blood product shortages, medication shortages, and stockouts. I am not very sure at Soroti referral, but I have a feeling that, and if someone really has witnessed stockouts of medications of antihypertensive, anticonvulsant, magnesium sulfate, and many other drugs that we use for management of eclampsia, please, you need to keep alerting the system so that because we know that it is among the causes of bad or worse outcomes in Soroti, in Teso, and many other regions in Uganda and in Africa, because there could be some other Africans from Kenya, from everywhere, who are listening to us or who are attended to us. Then we have rural isolation. You've heard about that much as Kampala is leading, but you did actually discover that the rural areas might be having worse outcomes because of factors connected to ambulance system, weekday ICU availability, antenatal, people are not aware, transport delays, all that kind of stuff. So preeclampsia classification has had classifications, and these classifications are not meant for really to be academic. They are meant to be for us to manage the patient better. The current classification is that we have preeclampsia with severe features and preeclampsia without severe features. Simply like that. Previously, some time back when I was an intern, we used to have mild preeclampsia, severe preeclampsia, but that one has been phased out. Reason being that preeclampsia is a progressive disease. Progressive disease, to the extent that you can see a patient today who doesn't have the severe disease, 3 days later or 2 days later, like the patient we saw, has features of severity or is dead anyway because of what does that mean? That's one. Two, the other reason is that some of the features of severity are not obviously visible. You must look for them. And therefore, you cannot just say patient because the patient has mild hypertension, which is systolic below 150, diastolic below 100, and then you call it mild preeclampsia. No, she might be having a low BP like this other patient. She had a low BP, but the other parameters were obviously bad, including the fact that she had an intrauterine fetal death. So we have this diagram is somewhere in one of our, I think, essential newborn, maternal and newborn care guidelines. It must be somewhere. And so please, it is something that you need to study very well, that you look at the patient and classify. Does she have preeclampsia with severe features? Does she have eclampsia? Eclampsia is one other form of preeclampsia with severe features, but it is unique in the sense that the patient has a convulsion or is unconscious. She has loss of consciousness or what we call altered mentation, and you cannot explain it. But it is another form of severity, please. And so when you get, then you go through. So you cover that a patient may just be having mild hypertension, but the laboratory have to be looked at, the imaging have to be looked at, and then so that you can classify fully. We cannot classify fully if we have not done those ones. So, and this is how we rule out features of severity. We can history, physical examinations, but we must also do laboratory and we do imaging findings. The reason is the patient might be clinically asymptomatic. Even examination, she doesn't have features of severity, like high blood pressure, severe hypertension. She doesn't have tenderness, epigastrium, tenderness, epigastrium. She doesn't have petechial hemorrhage. She doesn't have what. But you do laboratory and you find she has a platelet count of she has thrombocytopenia. She has creatinine high. She has liver enzymes high. All imaging, she will find that she has an intrauterine fetal death, she has IUGR, she has amniotic fluid index, she has biophysical profile. All those ones are imaging findings. Or she has a liver mass, because that is, we are only focusing at imaging of the fetus, but she can also be having a liver mass. For example, like our patient, later we actually discovered that we scanned afterwards, and she had several cystic masses, a number of cystic masses on the surface of the liver cups, meaning that she developed subcapsular blood accumulation even after treatment. So these are several other preeclampsia classifications. We have early onset versus late onset. We have based on gestation age, where we have preterm, we have term, we also have postpartum preeclampsia. That is also another classification. But what is important are the other classification, because it's the one which is helping us in terms of management. So preeclampsia with severe features, any of the findings, we are saying any, even if it is only one, doubling creatinine concentration, systolic blood pressure, impaired liver function, progressive renal insufficiency, or what we call another renal dysfunction. So any of these, and we are saying that any of these, you take history, you examine, you do laboratory, you do imaging. These are also some of the features of severity: platelet count, with or without DIC, with hemolysis, what we call HEP syndrome, pulmonary edema. This patient had acute pulmonary edema, which was worsened by her previous fluid accumulation, persistent cerebral visual disturbances. Some people might have seen a patient who presented to the hospital. I will never forget a patient who presented to the hospital to the hospital. The reason for presenting to the hospital only was she just lost sight. And when we took the blood pressure, we assessed her, she had preeclampsia with severe features. Actually, that patient, if I remember very well, she died because of acute kidney injury. And neurological complications, some people can get stroke, and she comes with a CVA. Uteroplacental dysfunction, IUGR, umbilical artery, Doppler wave, abnormal umbilical artery Doppler waveforms, or she can even have an IFD or stillbirth. Still, any of these findings, if there is a group of patients who have chronic hypertension, like I said, I didn't define the various forms of hypertensive disorders, but there is a group of patients who already are hypertensive or their hypertension occurred before 20 weeks. Those ones we call them chronic hypertension. And these patients particularly are at an increased risk of preeclampsia. And then when they develop preeclampsia, we call it preeclampsia, rather chronic hypertension with superimposed preeclampsia. Now, a person who was already hypertensive and all of a sudden her blood pressure was controlled by drugs, and then all of a sudden her BPs increase, or you need to increase the dose of antihypertensives, or she has a new onset proteinuria. We know that patients who are hypertensive generally can have hepatic renal nephropathy. They can have nephropathy. Now, if you have nephropathy, but it increases, the sudden increase in proteinuria for a patient who already had nephropathy, or she didn't have nephropathy, now she has proteinuria. That patient has a superimposed preeclampsia, much as she was originally hypertensive. This is exactly what we're talking about. A patient with chronic hypertension, her blood pressure suddenly escalates, or you need to increase the dose of antihypertensives. She has thrombocytopenia, rather hepatic dysfunction, or with features of hepatic dysfunction on HEPS3, or she has new onset or worsening renal dysfunction, pulmonary edema, persistent cerebral or visual disturbances. That patient with chronic hypertension automatically has superimposed preeclampsia if she is pregnant and she's above 24 weeks, or she is in puerperium and she's below 12 weeks. Eclampsia, we know that if a patient had preeclampsia and she has a convulsion, then that patient has eclampsia. Mothers can convulse with or without prior warning. Even with a non-severe blood pressure, they can still have convulsions. The cause of convulsions is not because of the high blood pressure only. No. The cause of eclamptic convulsions has many other mechanisms apart from the blood pressure. So we have pathogenesis and pathophysiology of the preeclampsia. It was not part of my assignment. So this one I will ask us to read and refer to it, because the management automatically has something to do with what we are talking about here. So management. The management is both assessment and then now you treat the disease. And when we are managing, we have goals to achieve. We have prevent or control convulsions. If a patient had severe disease, but she didn't have convulsions. If you remember our patient, she had all other features of severity, but she did not have convulsions. She was fully conscious all the time. Then we control blood pressure, hypertension, then we deliver the placenta by the safest and the quickest mode of delivery. And then post-delivery and long-term follow-up, we have to prevent reoccurrence in subsequent pregnancies for a patient who still has a desire to have children. Control convulsions. The antihypertensive of choice for eclamptic convulsions is magnesium sulfate. It is the antihypertensive of choice. There are many other antihypertensives, and they have been well studied, and magnesium sulfate was found to be magnesium sulfate was found to be superior to all the other anticonvulsants. So, and the mechanism of action of magnesium sulfate, they are, of course, if you're reading previously another old literature, they'll tell you that the effect is not clearly defined, but we know that it has both central and peripheral action. Peripherally, it is usually acts as a calcium channel blocker or calcium channel antagonist. And therefore, it causes muscle relaxation. Sorry. Okay. Centrally, it acts inhibiting excitatory neurotransmitters. It also reduces cerebral blood pressure, and therefore reduces a possibility of a convulsion. And that's why it is the best anticonvulsant for eclamptic convulsions. Reason being that the mechanism of eclamptic convulsions is different from the usual convulsions, as it has a number of mechanisms that do not only look at electrical firing, but also on neurotransmitter excitatory neurotransmitters. So the primary effect is through the central. Peripherally, it usually acts as much more as a side effect. All of us should be versed with the administration, with the loading dose, or should be well versed with the magnesium sulfate administration. We have two regimens. We have the Zuspan, we have the Pritchard, and in the developing countries, in the developing world, we choose the Pritchard, which is the one which is described here. Loading dose of 14 grams, and then IV 4 dilute the solution to 20% from 50%, and then you give the rest of the 10 IM55 on two separate buttocks, because it is one, very painful, two, it is bulky. 5 grams of magnesium sulfate is 10 mils, so you cannot inject more than 10 mils on one site. Otherwise, you can easily get an abscess because of the fluid accumulation. But it's also extremely painful, and we know that the one which is given IM is not essentially dilated. The maintenance dose, we give 5 grams of an undiluted solution. You have to put lignocaine, because if a patient is conscious, it is extremely painful. So you have to give a local anesthetic. And you alternately for about 24 hours, for at least 24 hours from the time of delivery or from a convulsion, whichever occurs last. That means if you were giving magnesium sulfate and somehow in the middle a patient convulses, then we count from that convulsion. Or if she convulses and we start magnesium sulfate, but then she has not delivered, then we shall wait until when we deliver the placenta, that's when we shall count down 24 hours. And this one has to be clearly understood because sometimes people give magnesium sulfate and you discover that they have stopped magnesium sulfate and the patient has not delivered. And shortly after or within before patient delivers, the patient gets a convulsion. And then people start saying, magnesium sulfate doesn't work, or we have full control conversion. But actually discover that there was a problem with the administration of magnesium sulfate. And magnesium sulfate is a very good drug, but it has a very narrow therapeutic window. And because it has a very narrow therapeutic window, we have to be on a watch out to make sure that we do not kill a patient with magnesium sulfate because it can be extremely toxic because of its narrow therapeutic window. So clinical assessment for toxicity, make sure the patellar reflexes, the tendon reflexes generally, but the patellar reflex tendon, rather the patellar tendon reflex is one of those tendons which are usually assessed respiratory rate, pulse rate, and urine output. Urine output specifically is not because magnesium sulfate is nephrotoxic. Magnesium sulfate is not a nephrotoxic drug. However, because it is exclusively excreted in urine, therefore its clearance depends on renal function. So you must be sure that the patient's renal function and therefore urine output is at its best. These are the signs of toxicity. They correlate with serum magnesium, and these are the serum magnesium levels. For if you're working in a facility which is very good to the extent that they can give you magnesium sulfate, serum magnesium levels in blood, then you are good to go. And these are the levels. So the tendon reflexes are the ones which they reduce. So they start reducing at 3.5, then by 5 they disappear. Then respiratory depression starts about 5. By 6.5, the patient is no longer able to move the muscles of respiration. Then the person starts getting cardiac depression about 7.5, and by 12.5 the patient will get cardiac arrest. So you can imagine, and this one might be very rapid. It may not be going through these small stages like we are looking at. It can actually happen very rapidly and give the patient rapidly as well. I will not forget one of the patients that we have managed before who got magnesium sulfate toxicity, and that one is a story for another day. We managed her and she recovered, but it was a nightmare. I had to stay in theater ventilating because we didn't have an HDU or an ICU to mechanically ventilate the patient. That was one. Two, the patient was conscious. We could not intubate her because of that, and because we didn't have an ICU possibly to do something else. I had to ventilate the patient, ambubag the patient myself for 24 hours. That is a story for another day. And the antidote is calcium gluconate. It is usually supplied together with magnesium sulfate. Please, if there is a person who is administering, or whose facility is supplied with magnesium sulfate and is not supplied with calcium gluconate, please, you put up your hand very early so that we help you, because the day you give magnesium sulfate and you get toxicity, you will lose that patient. So calcium gluconate is widely used in our country, I believe even in our regions. Calcium chloride is not one of those drugs that are widely supplied, and it also very toxic. It can irritate and even cause vascular necrosis if it extravasates from the vessel. Tissue necrosis if it extravasates from the vessel. The dose of magnesium sulfate in renal insufficiency, if the patient has renal dysfunction, and yet we must give magnesium sulfate, should receive a standard dose, loading dose. The loading dose is the same, but since their volume of distribution is not altered, but since they have a reduced renal clearance, then we have to reduce the maintenance dose. And these are some of the dosages that we can give. And like we said, once the patient is given magnesium sulfate, after 4 hours, we should be able to assess and see if her urine output is improving or is even getting worse. Because you can start with a good urine output and you end up with a worse, because we know that preeclampsia can become worse anytime. Serum creatinine 2.5, magnesium sulfate is present, no maintenance dose. If someone whose creatinine is 2.5 and above, or magnesium sulfate toxicity features are present, you do not give. So in Uganda, generally, if a patient has renal dysfunction, we have the dose of magnesium sulfate. Both, and we have said that this one is maintenance because the loading dose is the same. Before I go very far, on if you've given IV 4 grams here, and you have a pump, you can give 1 gram per hour of magnesium sulfate if you have a pump which can give you a drug of 1 gram per hour. It is allowed. That is what we call the Zuspan. That is for the maintenance. You give IV and then you put now magnesium sulfate in a pump, in a syringe and in a pump, and you connect and you set 1 gram per hour. That one is another, but this is the standard regimen for those of us who do not have pumps, who depend on manpower, not have automated pumps. Hypertension, blood pressure 140, 90. The hypertension is defined as such, and this threshold, it applies to whether it is chronic, gestational, preeclampsia. And antihypertensive medications, please note that antihypertensive medications do not prevent eclampsia or progression of the disease. The intention of anticonvulsants is mainly to prevent high blood pressure, the damage that can be caused by high blood pressures, especially a CVA or a stroke. And in pregnancy, hypertension is severe if it is 160 systolic, 110 diastolic, or non-severe if it is anywhere in between 140 systolic and 159, and 90 and 109. That is what we call the severe hypertension or non-severe hypertension in preeclampsia specifically. Treatment of severe hypertension. This one we use injectable antihypertensives. And we have a number of them. We have hydrazine, we have labetalol, and then you repeat the measurement in 15 minutes, between 15, 20, or 30, and should be repeated promptly, 30 to 60 minutes, should be lowered gradually over hours to days. You realize that once we bring down the blood pressure rapidly, we can also cause reduce placental blood flow, and we cause serious consequences, including abruption and all fetal compromise. So the drugs are labetalol, hydrazine, and nifedipine. Please do not forget that sublingual nifedipine was phased out, so do not give nifedipine sublingual. This is the dose of hydrazine, and this is the dosage of labetalol. If you are at a BMOC facility, you give the initial treatments, including magnesium sulfate loading dose, and then antihypertensives, and refer to a CMOC facility for continuation of treatment and delivery plan. This is how we treat our non-severe hypertension, and these are the drugs of choice, and these are the targeted blood pressures. Do not forget that we have a target blood pressures. The ultimate definitive treatment of preeclampsia is delivery of the placenta, because we know from the pathophysiology that is the origin of the disease. So we must treat the cause with the delivery of the placenta. And we use the most feasible, what do we mean? The quickest, but the safest mode of delivery. And we shall look at it. And delivery minimizes the risk of serious and maternal and fetal complications. We have already looked at the complications, and we shall continue looking at them. The fetal complications include these ones. Except for fetal growth restriction, any of these life-threatening complications can occur suddenly. It is only a growth restriction which occurs progressively. And the decision to deliver is based on, in their order of importance, maternal condition, fetal condition, and then finally gestation age. So you do not say, we are not going to deliver this baby because the gestation age is still below 34 weeks. But then the mother has a severe disease, or the fetus is already compromised. So you will not depend on the gestation age because of that. So, and this is the reason, this we have already stated the conditions when to deliver. Everyone who is preeclamptic and is equal to 37 weeks or above, please do not wait longer than 24 hours for you to make a decision to deliver. And for others, we are going to look at those ones who are between 34 and 36 and 6 days. We can only offer expectant management if there is no evidence of maternal or fetal compromise. And then these ones who are between 26 and 33, we prepare them for delivery if they have severe disease, but also even them when they have maternal fetal compromise, we deliver them. For eclampsia, we should make sure that within 12 hours, this patient has delivered. Preeclampsia of severe features, the delivery plan should be initiated within 24 hours, as long as, and these are indications of immediate delivery. I will not read all of them because we are time bad. These are conditions of expectant management. I will stress and say that preeclampsia is a progressive disease. So please, preeclampsia can only be managed in hospital, in the bed. And we have already said, if you're on a BMOC facility, for you, if there are features of severity, please do what we call emergency care and refer. Then, if you're in a hospital or in a CMOC facility, expectant management is on bed. Do not treat a patient as an outpatient, please. And then the other thing is that there are conditions for expectant management. Do not look at only blood pressures. You must do a continuum, a whole continuum of both history examination and investigations, including imaging, for you to say this woman does not have features of severity, and therefore we can prolong the progression of the pregnancy. Do not forget that we already said that antihypertensives do not stop the progression of the disease. And this is the continuation of all the conditions to fulfill for you to continue expectant management. Fetal risks include progressive restriction and demise. Most of the women that we have delayed delivery, unfortunately, we have ended up losing their babies. Even not long ago, there is someone we procrastinated to deliver and we lost the fetus. We lost the baby. We had to deliver fresh stillbirth, and that was not good. These are exactly the reasons why, and these are the components of expectant management. This is a summary of what we've been talking about. So these are long-term complications of a patient with preeclampsia, recurrent fetal growth restriction, preterm delivery, the great obstetric syndrome, stillbirth in subsequent pregnancies, just like that, chronic hypertension, cardiovascular disease, including coronary heart disease, chronic renal disease, diabetes, depression, anxiety, and PTSD because of what they have gone through. Mothers should be educated on these strategies to reduce their complications, and you must educate them exactly on all these things, including regular screening for what we have talked about, regular blood pressure monitoring, and contraception and preconception care, or preconception optimization prior to conception. So these are people who are at risk, at high risk, moderate risk. The reason why we look at high risk is that for these ones, in the subsequent pregnancy or when they conceive, we must do strategies to help us either prevent, which is the main strategy, but also detect early. Of course, every time we detect preeclampsia late, then we have severe consequences, like for the woman that we have looked at. So these are prevention strategies: primary prevention, low dose aspirin, calcium supplementation; secondary prevention, early detection strategies, BP monitoring, urine protein measurement, health workers training, like we are doing right now. Then when we have the disease tertiary prevention, magnesium sulfate, emergency care, delivery, ICU, HDU. Now you can see that we have serious problems. Then we have something like primordial prevention strategy. Before even people start look at a possibility of conceiving, at a population level mainly, education. And I think we are not doing well here, or we are doing well, but we need to increase to educate women so that they know that antenatal care and the preconception care and nutrition, all of them are such important strategies. Patient poverty eradication, this is a government function. Health infrastructure, building several health, other putting up what is required, ICU, HDU, antenatal care, providing BP machines, all that kind of thing. Low-dose aspirin as a preventive measure for one who we have talked about is at risk of preeclampsia, and our dosage is 150 milligrams daily starting 11 weeks. But do not go after 16 weeks, because after that time, the placenta is fully formed, and if there is a problem at the placenta, the person has already then their calcium supplementation is not yet widely used in our population in Uganda and in Soroti, but we shall consult with the, I think we shall consult properly if it is already on our essential drug list, so that we keep giving it to pregnant women, especially those ones who are at risk of preeclampsia. Its mechanism of disease, rather than mechanism of action of aspirin, is already described here. We were supposed to have early detection strategies. Like we said, early detection is another strategy. The prediction of patients has been a focus to predict patients at high risk of preeclampsia. It has been a focus in research, and the assessment for development of pregnant or prediction is key in efforts to reduce mortality and morbidity. And you will remember the two-stage theory of pathophysiology of preeclampsia. That's where we act in early detection strategies. And we have screening tools. We have history and examination, age parity, medical, obstetric history, conception method. You know that ART is artificial reproductive technology is a high risk factor for preeclampsia. Then we have metabolic risk profile, including BMI, history of diabetes, cardiovascular disease, including already pre-existing conditions. Measurement of mean arterial blood pressure has been found to be a predictive tool. And then we have uterine artery Doppler studies and umbilical artery Doppler studies, especially between the 13th and 11th, 13th weeks of gestation. When you measure uterine artery blood flow, and we have resistive index and pulsatory index and the ratio. If you look at that, we already have our radiologists or radiographers who have been trained to do those ones, and they are able to tell us that this is high, and therefore we can easily know that this woman is at risk of preeclampsia. And like we said, our preventing tool is to give them aspirin and calcium, and then we also have biomarkers. I think I already listed them here. And that's exactly, you can look at these strategies very well, that other factors, the ones that we're talking about, plus MAP, mean arterial blood pressure, uterine artery placental index, and these are biomarkers. PIGF at 11, 13 weeks appears to be most efficient screening model for identification of women at risk. I already have these articles. I'll share them with you for all of us to read. And the level of evidence, the grade of evidence, the grade of recommendation is A, meaning that it is highly recommended. Then we also have FICO 2019, all should be screened for preterm preeclampsia by the first trimester combined test. The risk calculator is available for fetal maternal facilities, and FICO encourages all countries to adopt such to ensure this. Best combined test is maternal risk factors, the one we have talked about, MAP, and like we have said above. And then you give them low-dose aspirin to be taken daily at night until 36 weeks. Should not be prescribed to all. Low-dose aspirin should not be prescribed to all women, but because it is only for those ones who are at high risk. You can read through these literature materials, and then they can guide us a little bit more. Sorry, I have overshoot, but this is part of what we had. I know I have rushed through a number of things, so we can ask questions.
Thank you. Thank you so much, Doctor, for such a wonderful presentation. And members, give Doctor his flowers. Click that emoji, the clapping emoji, the flower emoji. Let's shower Doctor with his flowers. He has done wonderfully. So would like to apologize. The session was supposed to end at 9:15, but we shall shoot a little bit. Give us a little 10 minutes of your time as we go through the question and answer session. So Doctor, you have a few questions on the chat. Let me just get to it and read through them. So someone is asking, is there any study to determine which adequate dose in milligram per kilogram body weight